All right. So our next topic is very broadly discussed, I would say, at this meeting. Even although the data were previously presented, we did have the follow-ups, which I would say didn't really show a lot. A little bit of follow-up data, but not a whole lot. But I think that what we're talking about is the combinations with daratumumab, with Revlimid and with Velcade. Really exciting data with the Pollux study, which is the one daratumumab Revlimid index, and then the Castor study, daratumumab Velcade index. And so my question that I'm going to be asking you moving forward is this really a game changer? I mean, are these data sufficiently better than what we've seen in the recent past to really make us think differently about the placing of the dara combos? And so just to put the exact numbers on the table, so if we look at the information for the Pollux study, this is daratumumab Revdex versus Revdex. Very good data, overall response rate 93%. And the thing that we've ended up focusing on is the top number, which is the hazard ratio for the difference for the PFS. So the length of the remission, the significance of the difference between the two curves. And this is a very low number, one of the, excuse me, one of the lowest that we've ever seen, actually. Mm-hmm. And you can see that it's about half of the hazard ratio for the Aspire trial. Now, what we've also said in the past, that it's absolutely forbidden to be making these comparisons. Right. However, the fact that it is such a difference, I think we're starting to maybe reconsider this. I'll be asking your opinion on that for sure. And then if we look in the Velcade or proteasome inhibitor-based combinations, we have similar information, a very low hazard ratio, excellent results, better than with carfilzomib, in this case panobinostat and elotuzumab. On the Revlimid side, we had daratumumab, carfilzomib, elotuzumab, and ixazomib or Ninlaro. So, based on these data, the Mayo team have really put a decisive recommendation on the table, which I want to get your feedback about. And they said, well, it looks like those dara combinations are really decisively good, and for this first relapse situation, they really should be considered as that first choice. And so, Joe, can you comment on this since it's coming from the Mayo team?
No, absolutely. I'm happy to do that. You know, I think you've said it well, Brian, that we can to some degree compare these trials. It's dangerous to push it too far. You know, as with each line of therapy in myeloma, there's less and less ease of consensus because so many other factors come in. We have quite a bit of consensus at this table and in the country on VRD up front and a transplant. As we start to relapse, it gets a bit more difficult. But I do think that these data are so impressive that including daratumumab at first relapse is very reasonable, very appropriate. Even the FDA, as you know, just a few weeks ago, has formally approved both of these combinations. Right. Now, when I sit down and look with a patient as to what they've been on, a lot of our patients are on lenalidomide maintenance, so the DRD isn't really a great option, although we sometimes might consider it. So we're more often in that refractory to lenalidomide where we can look at multiple options. But the fact that the monoclonal antibodies work so well, have really a lot less toxicity, except maybe on the wallet, but I think is actually, when we'll come to that, I'm sure, I think it's very appropriate to take this kind of approach. I think it's hard to make it just one regimen. We always have to look at the other options.
All the others.
There are times that we might use carfilzomib, there are times that we might use ixazomib, but in general, bringing the monoclonal antibodies early on, absolutely.
Yeah, so I think that this is a good segue to you, Sagar, because if we go back to this chart, if we go back to this chart here, the Eloquent study, as the principal investigator of this trial, I think that it's important for you to comment on the choice of the ELO combo, and how do you view this?
Yeah, I mean, I think that we can make sort of blanket recommendations, But the reality of many of these decisions is that there's a lot of factors that go into it. How far does the patient live from your clinic?
Okay.
Are they working? In which case, coming in once a week or twice a week is a real challenge.
Right.
You know, are there quality of life reasons that they'd rather be on an oral approach or a once a week or a once a month kind of infusion schedule?
Right.
Those all play into it. And so what we do is really think about, are they len sensitive or len refractory, as you showed there? Most of the trials with those really great or average hazard ratios, depending upon how you look at it, were done in a len-naive patient population. And so the fact that almost all of our patients are going to be on len maintenance now means that extrapolating these 4 data pieces to those patients is not exactly one-to-one.
Right.
And so for the patient that has a very indolent biochemical relapse on len maintenance, we may consider adding in ICSA and DEX. We may consider adding in ELO and DEX as a way to sort of get as much as you can out of all the drugs that you have available. If they don't fit one of those 2 categories, then our standard salvage would be to use pomalidomide plus daratumumab because they're a lenalidomide refractory patient.
Yes, exactly. So see, in this algorithm here, if you will, I think that you just said that with patients more likely to have become refractory to lenalidomide, we might be looking at the Dara-Velcade combo, or as you say, pomalidomide.
Right, right.
And so,
and you know that some of that is chosen from a convenience issue for patients. You know, not having to come in once or twice a week, depending upon how you do the bortezomib, is really a quality of life issue. And we've been really struck, and I know you have as well, by the POM-DARA interaction. I mean, POM is clearly a more potent immunomodulatory agent. It works in 17p deleted patients.
Absolutely.
And so in some of our early relapses with high-risk disease, that's been a really effective salvage regimen.
Yeah, so we could see some significant evolution here where that right box there could actually become Dara-POM-DEX because so much Revlimid has been used.
That's the difference between M-SMART and E-SMART, evolution.
Evolution, there you go.
Well played. Well played.
All right.
Score 1 for Lonial there. I'll give
right. So obviously it's going to affect all of the options moving forward. You know, you could have some other options and then additional options that we're going to have to
And I think
consider.
it's just so important what Sagar said around looking at a patient individually.
Yes.
Risk status may make a difference. If a patient has translocation 414, I probably won't reach for POM, but I'll reach for carfilzomib or bortezomib if they're not resistant to it.
Absolutely.
The travel issue, the frailty, and to be blunt, now some of our patients, some of the oral drugs are coming with significantly higher copays. Despite all the efforts that we have.
Financial aspects.
I recently had a patient, it was very hard for them to go on ixazomib, lenalidomide, dexamethasone, because the copay for each of the 2 was maybe reasonable, but the 2 together was not possible. So we had to think creatively of a different regimen.
And so I'm showing you a table here which was presented by Philippe Moreau at our satellite session. And just to emphasize, in the middle of the table, you'll see the minimum clinic visits that are required for a particular regimen. But we're looking at the burden of the particular regimen to the patient. Clinic visits, the scheduling and the route of administration, all these kinds of things. And so ultimately, you know, as you're saying, we need to be looking at all of these things. Very important.
Yeah, I mean, algorithms are really nice, especially in cancer. But the reality is we treat patients.
Yes, and you've got to figure it all out on an individual basis.
Right.
Absolutely.